Thank you for joining our Debbie's Dream Foundation Curing Stomach Cancer webinar series. Today's webinar is titled Beyond Surgery, Improving Outcomes in the Management of Stomach Cancer, and it is the 8th in a series of 12 webinars. I'm Mary Margaret Kilmeyer, and I'll be moderating today's webinar. I am the Programs Director for Debbie's Dream Foundation Curing Stomach Cancer and a licensed marriage and family therapist. My clinical and research background is focused on working collaboratively with doctors, patients, their families, and the members of a healthcare team. We would like to thank our title sponsors, Boston Biomedical, and our new second half title sponsor, EMD Serono, as well as our platinum sponsor, Lilly Oncology, for providing the funding to make this webinar possible. You will be able to ask questions during today's presentation. You can do so by typing your questions into the white text box that appears on your screen. However, today's speaker is currently traveling for a conference and was kind enough to pre-record his presentation, so questions will be addressed in the following days after the presentation. In addition, the recording of this webinar will be accessible on our website in the lecture library. First, I will share information about our president and founder, Debbie Zellman, and Debbie's Dream Foundation Curing Stomach Cancer. And then we will hear a presentation on improving outcomes in the management of stomach cancer from Dr. Omar Rashid of Holy Cross Hospital and Michael and Dianne Bienis Comprehensive Cancer Center before concluding the webinar today. Pictured here is the president and founder of Debbie's Dream Foundation Curing Stomach Cancer. Debbie was diagnosed with stage 4 stomach cancer in April of 2008, and as a practicing attorney and a mother of 3, she had no risk factors for stomach cancer, and her symptoms at the time were very vague. When she was diagnosed, she was told that her chance of being alive in 5 years was only 4%. She has endured harsh chemo regimens and targeted treatments and has experienced many recurrences over 9 years since her diagnosis, and she is still a patient to this day. Debbie founded DDF in April of 2009, just 1 year after her diagnosis. As an organization, we are a member of several advocacy coalitions, including the Deadliest Cancers Coalition, the Patient Equal Access Coalition, the State Patient Equal Access Coalition, and One Voice Against Cancer. Debbie has also served and continues to serve as a patient advocate on numerous committees and task forces that you can see on your screen. Some of you may already be familiar with facts and statistics about stomach cancer, and we are working to continually be updated and current with the trends and statistics. In 2017, it is estimated that more than 28,000 Americans will be diagnosed with stomach cancer, and more than 11,000 will die from the disease. 80% of all patients are diagnosed at stage 4, when the 5-year relative survival rate is only 5%, and the incidence rates in younger populations is increasing, while the expected frequency has been on the decline, and yet still in this country, very many know little about this deadly disease. Debbie's Dream Foundation is dedicated to raising awareness about stomach cancer, advancing funding for research, and providing education and support internationally to patients, families, and caregivers. Our ultimate goal is to make the cure for stomach cancer a reality. You can learn more about our mission and organization by visiting our website at www.debbiesdream.org. In the few short years, DDF has achieved many great milestones. We have 25 chapters across the United States, as well as chapters in Canada and Germany, and there are events ongoing around the country year-round. Our patient resource education program helps patients, their families, and caregivers around the world by matching them with survivors and caregivers using disease-specific criteria, including stage, biomarker, location, and much more. We host educational webinars like the one you're listening to today and symposia year-round, and our website contains in-depth information about stomach cancer that can be translated into more than 60 languages. As an organization, we have also been able to provide $650,000 in research grants, as well as advocating during our annual Stomach Cancer Capitol Hill Advocacy Day to add stomach cancer to the Department of Defense's peer-reviewed cancer research program. And these efforts have resulted in nearly $18 million being awarded to stomach cancer researchers. On your screen now, you can see a snapshot of our homepage with links to numerous resources, including our online stomach cancer support community, our events, as well as ways for you to get involved. Please visit our website for more information. And here you can also see some of the many events that we have ongoing year-round, upcoming in North Carolina as well as in Fort Lauderdale, Florida in the month of November are golf tournaments. The first in North Carolina taking place on November 4th, and the Fort Lauderdale Golf Tournament taking place on November 9th. We are hosting an in-person and live webcast of a stomach cancer education symposium that's taking place in Dallas, Texas on November 4th. This is an amazing event for an educational opportunity, and it will also be translated live for in-person attendees as well as for webcast attendees into Spanish. Then you can also continue to join us for other events throughout the rest of 2017 and look forward in 2018 to our 9th annual Night of Laughter, taking place on January 28th, as well as our local to our headquarters 8th Annual Stomach Cancer Education Symposium and 9th Annual Dreammakers Gala. You can find more about these and other events on our webpage and clicking on the Events tab. DDF is headquartered in Plantation, Florida. Our office hours are Monday through Friday from 8 a.m. to 5 p.m. Eastern Time. Also on this slide are important phone numbers and email addresses that you can use to contact our office and staff. We will now begin the presentation made possible in part by our title sponsors, Boston Biomedical and EMD Serono. The topic this month is Beyond Surgery, Improving Outcomes in the Management of Stomach Cancer. Our speaker, who, as I remind you, pre-recorded his presentation for us today since he's traveling. Our speaker is Dr. Omar Rashid of Holy Cross Hospital and the Michael and Dianne Bienes Comprehensive Cancer Center. Dr. Rashid's focus areas include surgical oncology, general surgery, and these are for multiple cancer types, including gastrointestinal cancer. He also works on minimally invasive robotic surgery and multimodality therapy, personalized precision medicine, cancer prevention, survivorship, rehabilitation, enhanced surgical recovery, and quality and value-based care. We thank him for his efforts in making today's presentation possible. And now we will start his pre-recorded presentation. The recording of the presentation may come through quietly on your computer or device, so I would please ask you to consider turning up your volume on your device as necessary. As a reminder, you can continue to submit your questions throughout today's presentation, and Dr. Rashid has agreed to respond to each question in the days following this webinar.
Hello, my name is Dr. Omar Rashid, and I would like to thank Debbie's Dream Foundation for the privilege and opportunity to speak to you today. The topic of today's webinar is entitled Beyond Surgery, Improving Outcomes in the Management of Stomach Cancer. The purpose of this presentation is to assist patients and survivors in understanding not only their diagnosis of gastric cancer, but the appropriate treatment based on stage. As you can imagine, gastric cancer is quite complex, and so I break down the management in 6 steps from establishing a diagnosis to achieving long-term survival. So my hope is that today, between this presentation and the opportunity to ask questions electronically, I'll be able to address many of your questions to empower you so that when you speak with your care team, that you'll become a better informed participant, and hopefully also it will lead to better outcomes. I have no financial disclosures other than the grants listed for precision medicine and oncology to improve access to genetic testing for patients who can't afford genetic testing for their tumors, as well as a grant to prevent and increase screening of colorectal cancer in high-risk populations. As you can see, I am located in Holy Cross Hospital, which is an affiliate of the Massachusetts General Hospital, and one of multiple hospitals in the Trinity Health System across 22 states. I'd like to dedicate this presentation to the incredible work that Debbie's Dream Foundation is currently doing and has been doing for patients and their families struggling with the diagnosis of stomach cancer. So to drill down in more detail about what the objectives are of this presentation, I spoke generally about the idea that from establishing a diagnosis to to achieving long-term survivorship, it is critical for the patient to be involved and their family in every aspect of their care with their team, and that the team places the patient at the very center of the decision-making. That's a part of the culture of our institution at Holy Cross, as well as my field. Remember, I'm not just a board-certified general surgeon, I'm also a board-certified complex general surgical oncologist, which means the patient and their cancer guide our treatment. It's not purely a surgical diagnosis. To that effect, that's the general theme of this presentation. As I go through the objectives, I'm going to reinforce those principles throughout with clear examples. So I'm going to start with an introduction about gastric cancer. Then I'm going to go into the historical role of surgery in gastric cancer to set things up for how it's evolved to the modern treatment today. And with that, I'm going to discuss advances in the surgical technique as well as advances in the non-surgical treatment. And quite frankly, they go hand in hand. You can't speak about gastric cancer surgery without discussing the non-surgical treatment options. And then finally, I'm going to provide some data for the listeners to hear about how is gastric cancer treated in the United States today. So to begin with the introduction, gastric adenocarcinoma is the 5th leading cause of cancer and the 3rd leading cause of cancer mortality globally. It's a worldwide disease. In the U.S., it used to be much more prevalent before our food supply had advanced, but currently there's been a resurgence of that diagnosis. It's one which unfortunately presents late in the course of disease. There's no standard screening regimen in the United States. And as a result, cases are usually identified as stages T3 or T4 with invasion of neighboring organs and distant lymph nodes. So what that means is, this goes back to the staging of gastric cancer. So every cancer, the way you're treated is, number one, establish a diagnosis. That's that first step. The second step is establishing the stage. How advanced is this cancer? And that's extremely important to understand, is there a role for surgery or should another treatment be employed? So gastric cancer begins here on the mucosa and then invades deep. So gastric cancer, it doesn't matter how big it is in terms of the size that determines treatment and survival and prognosis. It's the depth of invasion. So as you can see here, in situ, that's just Latin for in its own place. So if you have a gastric cancer that's super early, sitting here on the very surface of the stomach that has not invaded through here, then it's an early stage cancer. And then the deeper and deeper it goes, T1, T2, T3, T4, that's when you have more advanced disease. And as mentioned in the prior slide, most of the time in the U.S. and other parts of the world, quite frankly, gastric cancer is found at a later stage in T3, where it's going all the way down to the subserosa right here, as you can see on this staging description, or T4, where it's not only invading here, but it's going out and invading other structures. It can either go right into the serosa, which is this outer lining of the stomach that involves the lining, quite frankly, of the abdominal cavity. That's T4A, and T4B is when it invades adjacent structures. I don't depict it in this picture here, but I'll show you in other slides the involvement of the lymph node stations, as well as M, which is metastasis, actual spread to distant organs, not by direct invasion, but by cancer seeding and growth of new tumors in other organs. So what's the role of surgery? And how he was able to reconnect it to the stomach. This is what's called a Billroth 1 operation. Unfortunately, as you can tell from this slide, the patient passed away approximately 4 months later because she developed metastasis in her liver. So even though historically from that point up until very recently, the only option we had for what's called cured intense surgery, in other words, trying to actually remove the tumor without any evidence of disease to hopefully provide the patient the best chance of cure, that surgery is not enough. And so research continued about how we could improve not only the outcomes of the operation, but the long-term outcomes of these patients with gastric cancer, while at the same time not only defeating the cancer, but how do we improve the quality of life? How do we improve a meaningful longevity for our patients and their family? So what have been the advances? That's why if you have a tumor in the proximal part of the stomach, say here, if it's too close to this connection to the esophagus, removing only part of the stomach is not enough. You have to remove essentially the entire stomach and then reconnect the intestine to the esophagus. If it's further away, so you can get that 5-centimeter margin and still maintain proximal stomach, the stomach that's closer to the esophagus, then you can reconnect small intestine to that remnant stomach. That's one part of it. The second part is the lymphadenectomy, the removal of the lymph nodes. How far do you have to go? Can you just remove the stomach? Do you have to remove some of the lymph nodes? Or do you have to be so aggressive with removing these lymph nodes that you have to take part of the pancreas, which is this fish-like organ that sits here behind the stomach? This is the picture of the stomach of the body with the stomach removed. Do you have to remove part of that pancreas to get these lymph nodes, as well as the spleen, and even be more aggressive and peel off lymph nodes off of the aorta? How far is enough? In order to get as much cancer as possible, and as much information about the survival prognostics of that patient, so that you can provide them the best chance for cure. Well, this has been studied. In the East, they have traditionally been very, very aggressive, and the acronym is D1, D2, and D2 plus PAND, which is where you take the pancreas, the spleen, and also you go after the lymph nodes on the aorta, which is the major artery that goes down from the heart all the way down into the pelvis. And as you can see from these studies, and I know this is a very busy slide, but I do it to show how much research has been done in this area, just to understand the extent of lymph nodes. First of all, you can see here the numbers of patients that were involved. I included the list of countries involved because that's very important to understand what's going on in different parts of the world and where you are and where your treatment is. And so what you can see here, this is the morbidity, which essentially means what are the side effects of the surgery, complications, gets you that quality of life. More morbidity is bad because that means the patients are getting more complications. And you can see here the complication rates are quite high in the Western experience. In Taiwan, it's 7.3, but even in Japan, it's over 20-something% where patients have major morbidity. And this is the Italian experience. And then mortality, how many patients are dying? So in South Africa, it was 0. In Europe, I mean, it was a significant number of patients were dying from their surgery that was meant to cure them. And you can see with the little asterisks, there was a significant increase in the rate of mortality and of death when you did the more advanced D2 versus the D1. 6.5 to 13%, 4 versus 10%. In the Taiwanese literature, 0. In Japan, it was 0.8%, even when they did their very aggressive resection of lymph nodes. And then the Italian literature was the same, 3 versus 2.2. And here's survival. Even in the, so you can see there was no difference in survival, but even in the Taiwanese literature, there was a difference, but it was really only a 6% difference in this series, with an asterisk, so that's where you can see it was statistically significant. In the Japanese literature, there wasn't a significant difference, but this is comparing it to the extremely aggressive removal of lymph nodes around the aorta. And then in the Italian literature also, they showed no difference. So the take home here was that removing all these extra lymph nodes didn't really make much of a difference as long as you got enough lymph nodes. You weren't just taking the stomach and the surrounding lymph nodes. So doing that extended, super aggressive, classic lymphadenectomy that the Eastern countries have advocated in terms of the surgical associations did not provide a significant benefit. So in Western countries, we do an extended lymphadenectomy, but not to the point where we're going that aggressively. The other great advance that's happened has been minimally invasive surgery, and that includes laparoscopic surgery where small incisions are made. You're using a camera, and you can remove a large specimen with the 5 centimeters. So you can see it's not just a tumor, but it's that extended radical resection of the stomach with reconstruction, as well as a lymphadenectomy, where you can get all those lymph nodes out. And you can see here that the fatty tissue is what a lymph node essentially looks like. In addition to laparoscopic surgery, there has been the development of robotically assisted laparoscopic surgery, where the surgeon can utilize this novel technology to do more advanced techniques, such as the advanced radical resection and reconstruction, to try to reduce the length of time that the patient has to recover after the surgery because the incisions are smaller, And in concert with that, there has been the development of enhanced recovery protocols, which we also utilize to get the patients up and moving immediately after surgery and on a diet immediately after surgery, as well as offering them multimodality, what we call different types of pain management, not just narcotics, from nerve blocks to anti-inflammatories and other medications to attack the pain receptors, so to speak, from different mechanisms so that the patient will be able to walk immediately after the surgery, have minimal pain, and get to recover in a matter of a couple of days rather than a couple of weeks, essentially. So that's where surgery has come. But as mentioned earlier, in the case of Dr. Billroth in the 19th century, surgery was not enough. When you have cancer come back after surgery, just to break it down from a very biological standpoint, and so that the audience understands how we cancer surgeons think about cancer. When cancer comes back in the liver or in the lungs, far away from that stomach, it's not that there were a couple of cancer cells left in the lymph node and that lymph node tumor grew and that's where it came back. It's that the cancer was present systemically in the body, outside of the primary tumor. And so when that happens in cancer surgery, we as a field, and when I mean we, I don't just mean the surgeon, I mean the medical oncologist, radiation oncologist, the primary care doctor, everyone who's involved in the care of that patient, we consider that to be a systemic disease. And so we ask ourselves, are there options before or after surgery to use treatments that focus on the whole body, so-called systemic therapy, such as chemotherapy as an example? Is there an opportunity? Is there a benefit, quite frankly, for providing that treatment before or after surgery? Before the surgery, the technical term is neoadjuvant. After the surgery, the technical term is adjuvant therapy. Okay, and that's part of those 6 steps that I talk about. In addition, prior to undergoing surgery or even chemotherapy, we think about, is the patient ready? Have they lost a lot of weight? Do we need to get a dietitian involved? Are they weak because of their cancer? Do we need to build them up with physical therapy? So we call that prehabilitation. Rehabilitation is taking care of the patient after their treatment to get them stronger. Prehabilitation is building them up before. So we do that while we make the decision about how we're going to treat the patient. And then we get them to the goals they need to reach so that when they undergo their treatment, they'll have the best chance of success, so that they'll have fewer morbidity, right? So less side effects, less complications, lower mortality, and they can get back to the state that they were in before their cancer diagnosis more quickly and have more control over their life. That's the fundamental goal here. So once we decide that they're ready for treatment, then we have to provide the appropriate treatment. And this is where I really want to transition now into what are those non-surgical treatments that complement surgery to try to get us to a point where we don't have the outcome of that first gastrectomy, where the surgery was a success, but in a matter of a few months, the patient developed recurrent disease that was metastatic, distant to the liver in that example, that caused the patient to pass. And their progression-free survival. There were further studies also performed utilizing different regimens, because in the East, I always bring up this point about East versus West. In the Eastern countries, it was a lot more controversial, the role of their chemotherapy, and there have been multiple trials looking at it. And I don't want to belabor this point that much, but just to make it aware to you that if you're listening to us from countries in the East, it's important to talk about these differences and to speak with your multidisciplinary team if you're in Japan or Korea or China about what type of regimen you should have, and is there a difference in outcome depending on the treatments available in the East versus the West, and what are the reasons for that. So, as you can see here, we've talked about the concept that it's not just surgery, hence the title of my presentation. There's more to it than that. So how is gastric cancer treated? The other side of the coin of what I've described to you is that there are multiple trials. So is there really a consensus of how gastric cancer is treated in the U.S.? There's a lot of information, a lot of factors to consider. It's not just the opinion of the surgeon or even the cancer surgeon if you're seeing a dedicated cancer surgeon, but it's also the opinion of everyone else involved in that team up front. And so, because of all these controversies in the literature, it was our hypothesis that there was a great deal of variation in how Americans are treated when it comes to gastric cancer, both in terms of the regimen of treatment and also their outcomes in the United States. And so we looked at the epidemiology, the demographics, in other words, the patient characteristics, the different surgical options and chemotherapeutic options in terms of treatment of our patients, as well as their outcomes. And the goal of this is to help guide what's the best treatment for our patients. And so we hypothesized that there was a great deal of variability in how patients are treated. And furthermore, we hypothesized that there was no worse outcome after neoadjuvant treatment. Remember, giving chemo before surgery is neoadjuvant treatment. And so those opposed to that principle would say, well, if we give the patients chemotherapy before their surgery, then maybe they'll have worse outcomes. Maybe they won't be able to tolerate the chemo, and then they'll won't be able to undergo surgery. And so they've lost that window of cure, so to speak. Maybe because the chemotherapy has side effects and it's more difficult for patients to undergo the stress of anesthesia, the stress of surgery, and to be able to heal. It's not just removing that tumor, but when you reconnect the small intestine to the stomach, for example, or the small intestine to the esophagus in the case of total gastrectomy, the patients will have higher surgical complications because they've been debilitated, they've been weakened by the chemotherapy. Now, those are the arguments against providing chemotherapy before surgery. The arguments for it are that, number one, patients present as described in the introduction at a more advanced state of disease. Okay, so what does that mean? That means that our ability to stage the patient prior to surgery, if you believed in doing surgery and then giving chemoradiation if the disease was more advanced, if it was T3, and if the lymph nodes or if the lymph nodes are positive, then we have to realize that if we're given the chemoradiation after the surgery, then it's because we didn't know that their disease was more advanced before the surgery. And so if there's a high chance of patients falling into that category where they'll need the treatment, then why not treat them up front when they're more likely to undergo that chemotherapy, for example? That'll decrease the chance of that cancer from coming back. Because it's not the problem in their stomach that kills the patient. It's the problem in the stomach that's spread to other parts of the body, such as the liver, that comes back, and that is what causes mortality. And so, giving the chemotherapy up front, the patient's more likely to tolerate it. Gastric cancer surgery, even in the best hands, has complications. Even the patients who do well, they're weakened, and in some cases can't undergo the adjuvant chemoradiation. Undergoing chemoradiation after surgery, especially radiation after surgery where they have to treat the area where surgery has been, for example, is a lot more toxic. It's harder for the patient to undergo, in other words. And therefore, you're more likely to undergo that treatment if you do it before the surgery. Okay? Furthermore, you're able to see what happens to the tumor when you remove it. If the tumor didn't shrink on chemotherapy or grew and spread under chemotherapy, then that's a bad prognostic indicator. That tells you that maybe if it's spread on under chemotherapy, then it's probably a good thing the patient didn't undergo surgery because their outcomes would have been bad. If the patient couldn't undergo chemotherapy, for example, then you could argue, quite frankly, that the patient probably wouldn't do well with surgery. And so their quality of life and their outcomes would have been poor. So why put them through that? The goal is to treat the cancer and provide the patient some meaningful longevity. And then back to the point about the biology of the tumor. Giving chemotherapy up front tells you what the tumor does. And so if the patient doesn't respond, that's important information for the team. Because if the tumor comes back, if it spreads, then you know some information. You know it wasn't responding to the standard therapy. And then you can start thinking about other chemotherapy options, for example. Targeted therapy options, for example. Even clinical trials. So as you can tell from all these arguments I'm providing in terms of supporting neoadjuvant treatment, the trend in my field of cancer surgery, whether you're talking breast, esophagus, pancreas, in general, is moving, when you have more advanced disease, the trend is moving more towards neoadjuvant treatment based on these types of arguments. But obviously, arguments don't guide treatment, data guide treatment. And so part of the goal of this study was to get at those questions, quite frankly, to help guide clinicians and their patients. Because while these theories sound convincing, the proof is in the pudding. What are the outcomes for the patients? And so what we did was we looked at the CMS database, the Medicare database, right? And we looked at all these different questions of patients with gastric adenocarcinoma. Now, mind you, this database was limited because it's based on financial information. What does that mean? That means that we found the patients based on their diagnostic codes used for billing Medicare. So we don't necessarily have the most specific information about their stage and other clinical information, but it does give us a sense of how patients are being treated within the CMS database. It's also limited by, obviously, we're only looking at patients who qualify for Medicare and undergoing treatment under Medicare, quite frankly. So that does limit a little bit, obviously, the patient population. But having said those limitations, there were a total of nearly 200,000 patients in this database having a diagnosis of gastric adenocarcinoma. And of those, 59%, so 115,522 patients, were identified as patients that underwent medical intervention for their gastric cancer, okay? So, what were the metrics we're looking at? Well, one of the proxies for morbidity and mortality, in other words, one of the outcomes that give us a sense of what their complications were after surgery is length of stay. How long were the patients in the hospital? And we compared patients who underwent surgery without chemotherapy first to patients who underwent chemotherapy and then surgery, so neoadjuvant chemotherapy and then gastrectomy. And what we found was, on average, the length of stay for the patients who just underwent surgery was 14.326 days, compared to the patients who underwent neoadjuvant chemotherapy and then surgery. The length of stay was 12.994 days. And when we did a statistical comparison, there was a significant difference. For us, quite frankly, the bare minimum was to show that there was no worse length of stay, right? Worse outcomes than the group that underwent surgery. So that was a very powerful, interesting result. Now, when you look at this, you always wonder, well, you're looking back retrospectively, this wasn't a randomized controlled trial, so you weren't necessarily comparing apples to apples when patients were undergoing surgery versus chemo and then surgery. So there could have been what are called confounding variables, confounding factors, other issues that popped up that might have skewed the results. So we think there's a difference, and there's not really a difference. And so one way to look at that is what's called the Charleston Comorbidity Score that's available in this database. It's a way to measure how sick these patients were. So what does that mean? That means the more points you have, the more other health problems you have. So that to give you a sense, are we dealing with an even playing field, or was one group a lot healthier than the other, and that could translate to why their outcomes were better? Well, when we looked at the two groups, the patients that underwent surgery alone, their average comorbidity score was an 8, whereas the group that underwent chemotherapy and then surgery, their average score was a 9, so there was no significant difference. Finally, when you have length of stay, the other question we had was, well, how was that length of stay? In other words, when you were there in the hospital for 14 days, were you just hanging out on the floor, right, with no major problems, just waiting to meet criteria to go home? Or were you sick in the ICU, requiring extra interventions? So it's hard to get that from this database necessarily, but one way we did was to actually look at the cost that was charged. And so the idea being that if the cost charge was significantly higher in one group versus the other, then that would indicate that more stuff was going on, essentially. More complications were taking place that had to be intervened on. And as you see here, the average charge was approximately the same between both groups. And then finally, when we look at outcomes, it's not just are the patients leaving the hospital, but are they being readmitted? Are they coming back to the hospital because they're sick? Are the complications showing up later? Or are they so weakened by their treatment that they're developing other problems like pneumonias, etc., and that's requiring them to come back in the hospital? That's why we look at readmission rates. And as you can see here, the readmission rates were pretty low, and it was 5.5% in the surgery-only group versus 4.45% in the chemo, then surgery group. So what does this tell us? This tells us that based on our analysis of this database, that there was no significant worsening of outcomes or cost in patients who underwent chemo and then surgery versus surgery alone in terms of their perioperative stay. In other words, their surgical experience with the surgery, recovery from surgery. And the reason why we designed the study again was to get at those questions, to get at those debate points about what's the role of, what's the impact of neoadjuvant chemotherapy on the patient's perioperative recovery. Obviously, further research has to be conducted to look at the relationship between length of stay, comorbidity scores, the types of treatment, and the demographics. But at least this gives us a very early depiction of how they're treated. So what does this mean? So most centers that treat patients with gastric cancer, and you can see the guidelines in the National Comprehensive Cancer Network and the different institutions involved in that process, as well as surgeons such as myself who've been taking that extra fellowship training and board certification in complex general surgical oncology. When we see a patient with gastric cancer, as surgeons and cancer surgeons, we approach it as a team. So what does that mean? So we have multidisciplinary tumor board conferences where we look at the patient and we discuss the whole case. And it's not just a surgeon, it's also the medical oncologist, radiation oncologist, pathologist, the radiologist, you have the social workers there, the dietitians, the whole team, the nurses, and in some cases also the tumor registrars, in other words, the folks who are entering the data into our database, all those different team members together with our guidelines, international and national consensus guidelines on how to treat patients. And we go through a very step-by-step process where we confirm the diagnosis, looking at the pathology, reviewing the slides, we confirm the stage. So what's the stage of the patient? So in our situation, not only would we want to see the biopsy proving it on endoscopy that it was gastric cancer, we'd also want the endoscopic ultrasound to see how deep that stomach cancer is invading, and also to see if the lymph nodes surrounding it appear abnormal. We would also want imaging, such as CT scans and PET scans, to see, is there evidence of this tumor spreading? Is there that M1 disease, right? That metastatic disease to other organs. At the same time, we're looking at the whole person. Are they depressed? Do they need support? Do they need access to support groups, for example, to help them understand their diagnosis? Are they debilitated? Do they need prehabilitation? What's their weight? What's their goal weight to undergo treatment based on their age? What's their physical status, and how do we build them up as much as possible? The other question is, where is the tumor? So I bring up the C-word classification. I don't mean to put too much of a tangent, but there are a lot of tumors that are appearing at the junction between the esophagus and the stomach. And these lower tumors, the C-word 3s, fall into that gastric category. But be that as it may, the purpose of this presentation is really to focus on gastric cancer. So at the very, very beginning, when we discuss it as a group, we classify the patient into all these different categories. And we do that in a fashion where it's based on consensus. Everyone has to agree on the stage of the patient and their status. And then we break, this is where the decision tree then moves from reviewing the patients and saying, okay, are they T1? Are they very early stage where it's only invading that very superficial level? And we can offer the patient surgery with enhanced recovery and minimally invasive techniques. And if so, then we offer them that treatment and then review the final pathology and say, okay, does this patient fall into a category where they would benefit from further treatment, such as chemoradiation, as discussed from that table early in the presentation? If that's the case, then we go to that treatment, and then we go on that final step of that 6-step process, which is, what's our long-term survivorship plan for this patient? How can we improve the side effects from treatment? Because there are going to be some side effects from treatment, unfortunately. It doesn't matter. Even if everything is a quote-unquote success, the patient's quality of life is going to change. So how do we improve that? What type of surveillance regimen? Even though the patient's been through all the treatment, there's still a risk of that coming back. And so we have to come up with a plan for how often the patient needs to be imaged, what type of imaging, blood tests, etc. Now, that's if it's T1. If If it's T2 or greater, which, as alluded to in the very beginning of this presentation, most patients are, then the staging is not complete. We have to do one more staging test, which is laparoscopic surgery, where we go in with a camera, we look around, we do ultrasound of the liver to see if there's signs of small tumors in the liver that we're not seeing in other imaging. And then we also do washings, which is where sterile saline is used to wash the abdomen in all quadrants and sent out to the pathologist to see if little cells had escaped, so to speak, have spread in that area. And if it's positive, if it appears that the gastric cancer has spread, then the patient is considered to be stage 4. And then we allocate those patients to systemic therapy. We avoid unnecessary surgery, because at that point the proverbial cat is out of the bag, right? The cancer cells have already spread, and so the treatment must be systemic to treat all the areas that have spread. If these washings and this whole staging is negative, and mind you, it's major surgery, but it's minor in the sense that it's minimally invasive, the patient goes home the same day. It's major in that you're entering the abdomen, but aside from that, it's a surgery that's very well tolerated. If it's negative, then we hold the patient as not having stage 4 disease, and we move forward on the magic trial, the trial from the UK, their regimen, where the patient is given chemotherapy, and then the patient is restaged. So we give the 3 cycles of chemotherapy, we being the multidisciplinary team, it's a medical oncologist, obviously not the surgeon. And then we say, okay, that we've done the treatment, let's have the patient recover from the treatment, see how they did, and let's see how the tumor did. And that's where the patient gets a repeat endoscopy to look at the tumor. The patient gets scans and PET scans to look and see, has the tumor spread? And at that point, we then discuss what's the next treatment. In some cases, if the tumor appears to be very, very advanced, the staging laparoscopy might need to be repeated. But most of the time, it won't. In that case, if it appears the tumor has shrunk or has not spread, if it has spread, obviously, then we go back to systemic therapy. If it has not, then, and we confirm that we're somewhere in this area, then we proceed to surgery, as alluded to before, where we do the robotically assisted surgery or laparoscopic surgery or open surgery, depending on the patient characteristics, whether or not it's indicated. It's not a cookie cutter type of approach. It's a personalized approach where each patient, their treatment is tailored for them. And we do that with an enhanced recovery protocol to get the patient through the treatment as safely and as quickly as possible, because we know they're most likely going to require more treatment, either more chemotherapy or radiation, depending on what the multidisciplinary conference says based on the pathology and how the patient did, and based on the consensus guidelines. And then we proceed with, once they finish all their treatment, their survivorship plan. So this is not only our approach, but how most approaches are in places where they're used to treating gastric cancer. And it's very important for patients, I know this is very complicated, but it's very important for patients to understand this process. It's challenging, and that's why I break it down into those 6 steps. Number 1, establishing the diagnosis. Number 2, establishing the stage of diagnosis. Number 3, preparing the patient for surgery or chemotherapy. What's their fitness? If obviously you're an early stage cancer, but you're not fit for treatment because your chances of dying from the treatment are high, then you have to modify things, either improve the status of the patient or come up with less toxic therapy so that the patient can treat their cancer and not die from the treatment, so to speak. Then the next stage would be the actual treatment of the patient. That's 4. Number 5 is, what's the response to the treatment? Is there any other adjuvant treatment, right? So looking at the pathology as mentioned here, et cetera, and then should they get more chemo, should they get chemo radiation, depending on what their treatment was. And then 6, the final step is survivorship, long-term survivorship. And as you can imagine, going through this process is not easy. And so I encourage you to take advantage of the resources of the Debbie's Dream Foundation, for example, and other resources online to make you as informed as possible as you go through these different steps. So this presentation has been helpful. I'd like to thank you again for your attention and for your time today. I hope it's answered a lot of questions. I'd like to thank Debbie's Dream Foundation especially for the privilege and opportunity to give this presentation, and I'd be more than happy to answer any questions.
And that concludes the presentation from Dr. Rashid. And we will leave the webinar open for a few minutes to allow any final questions to be submitted through the webinar portal. You can also send your questions to our staff by email. Any and all questions that are sent will be compiled and sent to Dr. Rashid for responses. If you tuned in late, the presentation for today by Dr. Rashid was pre-recorded as he was traveling for a conference, but he has agreed to respond to questions as available in the few days after the presentation. So please send your questions through the portal or send them by email to any of our staff members. I would like to thank Dr. Rashid for his efforts and for sharing his expertise with us today. As you know, this webinar was brought to you by Debbie's Dream Foundation, Curing Stomach Cancer. The recorded version of this and past webinars can be found in the lecture library of our website. Thank you again to our sponsors who helped make this webinar possible. Our title sponsors, Boston Biomedical and EMD Serono, and our platinum sponsor, Lilly Oncology. As a reminder, please check our website and your calendars and join us for an event coming up near you. Thank you to all of our listeners today. This concludes our 8th in a series of 12 webinars. Our next webinar will be held on October 20th at 12 noon Eastern Time. To view recorded webinars, please visit our lecture library. We would love to hear your feedback, questions, and thoughts. Please send your comments to patient.resource@debbiesdream.org. Thank you for joining us.